We are glad you could join us today for key findings from MD Ranger's 2024 Benchmarks webcast. I'm Evan Rossborough, a Business Development and Marketing Associate at ECG, and I'm pleased to moderate for today's program. In this webinar, we will review and discuss ways in which healthcare providers use MD Ranger to set payment rates, document fair market value, and comply with federal Stark and anti-kickback regulations. MD Ranger is used by hundreds of healthcare organizations, including hospitals, health systems, trauma centers, medical groups, LTACs, outpatient providers, and critical access facilities. Each year, MD Ranger calculates compensation benchmarks from a variety of physician transactions. Over 1,600 benchmarks are available to help determine and document rates. In addition to salary and productivity benchmarks, MD Ranger has rates for ED call coverage, medical direction, administration, hospital-based arrangements, clinical hourly rates, diagnostic testing, telehealth, and more. We will review key findings from MD Ranger's 2024 benchmarks in today's webinar. Before we begin the formal program, let's go over a few details about the webinar. Today's program will be about 45 minutes in length and will include 35 minutes of presentation and about 10 minutes for question and answers. Everyone should have received a copy of the session handout, but if you are a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen mode only, but if you have questions, you can type them in the question pane on your screen at any time. We will address them at the end of the formal presentation. If we're unable to answer all of your questions today, we will follow up with you after the session. And finally, upon exiting today's program, you'll be directed to an electronic survey. Your feedback is important to us, so please take a minute to complete the survey. For each completed survey, ECG will donate $5 to Doctors Without Borders. Now let's meet today's speaker. Allison is a healthcare and product and strategy executive with 18 years of industry experience. Her career has been marked by a consistent track record of guiding and executing corporate strategy while building high-performing teams across commercial and product divisions. As a leader of ECG's MD Ranger practice, Allison is responsible for growing the scope and value of the product. She has a passion for understanding the needs of healthcare leaders, translating that knowledge into user-friendly technology products and that can scale across organizations. Welcome, Allison.
Thank you so much, Evan. It's great to be here.
We have a lot to cover, so I will turn the presentation over to Allison.
Thanks, Evan. I really appreciate the introduction. And before I address any of the content today, I just want to take a moment to thank the entire MD Ranger team who worked really hard this year producing our benchmarks and helping to put together the presentation I'll be sharing with you today. On the next slide, we will see our discussion plan for today. We're going to discuss key findings from our 2024 benchmarks, including factors that influence rates. We'll definitely have some time to introduce both ECG and MD Ranger, but really the bulk of the webinar is going to be sharing new benchmarks with you. Throughout, I'm going to also highlight new and emerging trends for hospital physician contracts and compensation. On slide number 4, this is our first key findings webinar after joining ECG Management Consultants. MD Ranger was acquired back in December, and we've loved becoming a part of this awesome company. Now, I understand there are people on the line who might not know that much about ECG yet, but they've been MD Ranger subscribers for a long time, and also vice versa. So I do want to take a couple of minutes today to share a bit more about both ECG and MD Ranger. So for those of you who are new to ECG, I'm delighted to introduce you to our new partner. I find it easy to get to know the company by way of a handful of key statistics about our firm. First, we recently celebrated our 50th anniversary, and since our founding have been exclusively focused on healthcare. We're the only dedicated healthcare consulting firm that offers the scope, breadth, and depth of services that we do, and more on those services in a moment. While ECG has had a long history of serving academic and pediatric clients, we also work with large integrated health systems, community hospitals, and critical access facilities. ECG is a national firm with offices in 9 different locations and has very tenured consulting staff, particularly at senior levels. MD Ranger was a women-owned firm before we were acquired, so I'm also extremely proud to mention that half of our management committee is composed of women, and we're very invested in developing strong female leaders. On slide 5, as you can see, ECG provides a full range of consulting services to support healthcare organizations. Here are our major consulting practice areas so you get a sense of how we work with clients. While I'm tempted to go into detail because we have some talented people in these practices doing excellent work, I do encourage everyone to explore ECG's offerings and areas of expertise on our website, ecgmc.com. Now on slide 6, I do want to spend some time talking about a very closely related practice at ECG to MD Ranger. We are closely aligned with ECG's provider financial services practice, which includes both compensation design services as well as valuation services. My colleagues in this space do great work helping organizations align with their providers. ECG experts render thousands of fair market value opinions each year, and in fact, I'm going to be sharing some quotes and insights from these experts during the webinar today. MD Ranger is proud to be close to this practice, and we've already seen the benefits from our partnership with these experts. On slide 7, many of you likely know that ECG has been administering and publishing compensation surveys for more than 25 years. In fact, it was their expertise in this space that led MD Ranger to want to partner with ECG. ECG surveys for physician and APP compensation will be available in MD Ranger in just a few short weeks, taken from 2023 data, as well as available to all those who participated in that survey. The survey team will host a webinar where they will highlight key trends and key findings later this year. And on slide number 8, last but certainly not least, I want to introduce MD Ranger to those of you on the line who aren't familiar with our web-based product that helps automate the FMV process. MD Ranger helps healthcare organizations streamline compliance with market data and documentation features. MD Ranger Analytics can help organizations determine the scope of their hospital physician contracts and determine if spending is in line with peer organizations. If you find our benchmarks helpful and you'd like to explore how MD Ranger can be deployed at your organization, please reach out to us following the webinar and we'd love to discuss with you. On slide 9, as we start to talk about trends and benchmarks, it's important to distinguish what types of transactions we're going to be discussing today. MD Ranger surveys contracts between hospitals and physicians, not physician employment agreements. So today's discussion is going to be centered around transactions such as ED coverage arrangements, medical directorships and other administrative agreements, and hospital-based services arrangements such as hospitalists, emergency medicine, anesthesiology. You get the picture. ECG is releasing benchmarks for compensation and productivity for physicians and non-physician providers such as APPs at the end of the month. Okay, so now that we've got that clear, there are a number of market forces as well as changes in the way medicine is being practiced that are influencing the way doctors and hospitals contract with one another. First, we're seeing fewer doctors who are willing and able to do on-call and administrative work at hospitals. This trend is driven by various factors, including, of course, burnout and a desire for a better work-life balance, as well as generational shifts and differing expectations. Next, we're facing physician shortages coupled with scope of practice differences that are evolving over time. This shortage is becoming more pronounced and is leading to a reevaluation of how healthcare professionals can work together more effectively to deliver the best patient care possible. Now, while we won't get into bigger workforce trends in this webinar, we have addressed the transformation undergoing the healthcare workforce and other thought leadership that we've produced at ECG. So I encourage you to check that out if you haven't already. We're also seeing a rise in more part-time and employed physicians. Many doctors are opting for these types of roles or choosing employment over private practice, again, for lifestyle and stability reasons. There's also a growing bifurcation of hospital versus office-based specialties. Specialties are also becoming more distinct and subspecialized, which of course impacts workflow, patient management, the allocation of resources, demand for services, and more. And then lastly, there of course is the movement towards pay for performance or value-based care. This shift aims to improve healthcare outcomes by linking comp more directly to quality, and no doubt has impact on provider transactions. On slide 10, meanwhile, of course, the federal government remains steadfast in pursuing healthcare fraud as a priority. The Department of Justice will continue investigating cases, especially given the strong return on investment that they see. A total of $1.9 billion was recovered from healthcare settlements and judgments in 2023 alone. So the feds continue to see great ROI from these investigations. And of course, it has a huge incentive to protect our taxpayer dollars from fraud and abuse. Given the overturning of the Chevron doctrine just 2 weeks ago, there's some uncertainty as to the role of government agencies when it comes to enforcing regulation. Frankly, this change could have some significant impacts on the healthcare industry in the future. However, it is important to keep in mind that your organization should continue to uphold compliance and business best practices that are maintained with F&V policies, compliance procedures, and good governance. We're not living in the future yet, and the DOJ will continue to pursue fraud and abuse in healthcare with so much at stake. Now on slide 11, given all the regulatory scrutiny and the dollars spent on these types of transactions, not to mention that clinicians are a hospital organization's most important asset, if your organization doesn't have a policy for the F&V process, it's at risk. The good news is that you don't have to reinvent the wheel. Even straightforward and simple policies for compliance documentation will help mitigate risk. At ECG, we have templates and tools for folks that want to put together simple policies for managing the F&V process. We also have great consultants like Kate Taylor from the previous slide who can help your organization with governance. Using technology can also help automate your process and ensure that your transactions have consistent documentation. Regardless, though, of however you go about structuring your guidelines and your processes, because there are a lot of different ways to do it, it's important to ensure that they are effective for your organizations, comply with regs, and help you remain compliant. So on slide 12, let's get into the data. One of our most consistent findings from year to year is that our benchmarks are incredibly consistent and stable from year to year. The chart on this slide illustrates the point. Now, generally, while rates trend subtly upwards like comp typically does, most contract rates do not change year to year in our database. Let's look at impacts and increases broadly over time. So if you focus on the darkest colored sections of these bar charts, those are the contracts that stayed nearly the same payment year over year. And as you can see over the past 5 years, ED call and direction have remained pretty stable. Hospital-based contracts continue to show the most movement, or we could even say volatility over the past 5 years, although in 2024, fewer contracts increased more than 10% than in prior years. Our review of these transactions suggests that it's likely that the changes in CMS payments and the No Surprises Act negatively impacted collections for many hospital-based services, which of course results in demands for higher hospital support. We also suspect that more round-the-clock coverage in these agreements and increased interventional and subspecialty services are also being incorporated into contracts, which clearly impacts rates too. On slide 13, I just want to show you some of the specialties we consider hospital-based services. Historically, there were only a handful of these services, and most of these were basics required for a hospital's license. But over the past 3 decades, hospital-based services have evolved. So starting in the 90s, we see some emerging newer hospital-based specialties like hospitalists and intensivist programs. But over the past decade or so, we've seen new hospital-based specialties emerge, driven by accreditation requirements, positive clinical outcomes, physician shortages, and evolving preferences, and other trends that have increased the separation of inpatient and outpatient medicine. Now, while we don't have benchmarks for the service quite yet, GI hospitalists have definitely been a trending topic within our consulting practice recently. We've seen hospitals try to build out these programs, but recruiting physicians has been a challenge. Many GI docs don't want to be dedicated on the inpatient side. And the key challenge has been rationalizing their pay given the variability in coverage requirements. If your organization does need help building GI hospitalist programs, or frankly, any other emerging hospitalist program, definitely reach out to us and we can connect you with the most appropriate expert. On slide 14, I don't want to linger on this slide too long, but I wanted to insert it for clarifying purposes. So when we're thinking about hospital-based services, just some key characteristics to define. You want specialization and recognition. Both are very important. There's a specific patient base. And then lastly, exclusivity. Many hospital-based programs do grant contractual exclusive coverage of the service to a group of doctors. Next slide. On slide 15, hospital-based stipends have become the biggest part of many hospitals' total annual spend, with the median hospital in our database spending just under $4 million alone on hospital-based stipends. My colleague, partner Rory Young, states in our press release from last month that the new benchmarks illustrate what we're seeing in our valuation practice at ECG, which is increasingly complex and expensive contracts for the coverage of hospital-based services. Fewer hospitals are compensating physicians for coverage of hospital-based services on a per diem basis, while overall stipends with larger groups are becoming more common. This trend is seen especially in OB or laborious programs. The prevalence of high-risk pregnancies have doubled in recent years, which has led many hospitals to invest in laborious programs to both provide support and mitigate risk. This, paired with physician shortages and the desire for less burdensome call rotations, have led hospitals to invest in reliable coverage via these laborious groups. Now, hospital-based physicians are facing growing challenges resulting from the implementation of the No Surprises Act and decreases in Medicare rates. That's not the first or the last time I'm going to reference the No Surprises Act today. My colleague, Penny Stroud, who's a principal at ECG and one of the founders of MD Ranger, stated also in our press release, with a growing shortage of physicians in specialties like anesthesia and radiology, doctors are looking to hospitals to assist in the recruitment and retention initiatives, and those are embedded in stipends and hospital contracts. So on slide 16, I definitely want to take a minute to discuss some anesthesia trends, which is also perennially a hot topic. Anesthesia costs have steadily increased over the past 5 years, which has been driven by growing demand for services in less clinically efficient settings like NORA sites. This trend, which predated the pandemic, has been exacerbated by a growing workforce gap, where there are only 4 new anesthesiologists to join the workforce for every 5 who leave. And this is a gap that can't be adequately backfilled by other providers such as CRNAs. And of course, the No Surprises Act has granted additional bargaining power to commercial payers. That puts downward pressure on private groups to stay in network at reduced rates. Over the past handful of years, 5 or 6 years, this confluence of trends has increased the gap between the cost of anesthesia providers and the professional collections that they generate. Health systems, no surprise to you, are being asked to fund the difference. And I feel like if we had a cartoon on this slide, it would be a picture of a hospital facility kind of squeezed in between 2 gigantic boulders. Since 2020, anesthesia annual payments excluding medical direction have increased more than 70% at the median and almost 50% at the 75th, percentile. Other services did experience increases this year though, so I don't want to leave them out, including radiology, emergency, and trauma surgery, whose median benchmark increased more than 20%. At the median, trauma surgery and general hospitalists were the highest cost hospital-based service at almost 1.8 million. However, at the 75th percentile, anesthesia exceeded trauma surgery at 3.9 million. It is very important to note that hospital service spending varies wildly by service, as you can see on the next slide. Here we're looking at median total annual payments by specialty, which ranges from trauma on the high end to pathology at the low end. Now, I want to be very clear that the payments you see on this screen are payments made to a group of physicians to provide the service to the hospital. They include a wide variety of components, like, but please note that these are not individual physician salaries, and also important to keep in mind, 20% of the contracts in our database don't have any payments received from hospitals. So they are quote unquote unpaid. On slide 18, hospital-based physician contracts are expanding in size and scope, covering more specialties than ever before. There's now financial support for a wide range of specialty teams, including psychiatry, obstetrics, orthopedics, neurology, neurointensive care, and acute care surgery. You can see on this chart, which illustrates increases in median payments over the past 3 years. Interestingly, in 2024, the only service not to have increases was pediatric hospitalists. On slide 19, hospital-based agreements are continuing to incorporate incentive payments as value-based payment models dominate conversations about comp models in the industry. 40% of the hospital-based contracts in our database do include incentive elements. Quality initiatives have outpaced other incentive components for a number of years. On next slide, slide 20, in this chart, we're tracking incentive components in hospital-based agreements over the past decade. You can see the growth and the fluctuation of these components over time. The inclusion of incentives do continue to increase, though we did see a slight dip following the peak of COVID. Outsized increases due to COVID, deteriorating hospital finances, many things could have caused it. It's difficult to determine the causation. However, it will be interesting to see how incentive components evolve and develop over the next handful of years. Now, in slide 21, I would like to shift gears and start talking about trends for medical directorships and physician administrative positions. Administrative benchmarks, particularly hourly rates, are quite stable year to year. Medical direction and administrative hourly rates are almost identical to the prior year, with about 90% of the services in our database within 10% of last year's rates. For annual payments and annual hours, only about 50% of those services are within 10%. On slide 22, likely to no one's surprise, we do observe a bifurcation in medical director rates between medical subspecialties and surgical specialties, which is kind of hard to see at first glance, but if you note the vertical axes on these charts, you'll see that they do have different scales. This is attributed to opportunity cost differentials to serve in administrative roles, given that surgical specialists generally have higher income from their clinical practice. On slide 23, moving away from hourly payment trends to annual payment trends for administrative services, I want to show you how things have been evolving over the past decade. When we're talking about traditional medical directorships, the average payment for medical subspecialties have stayed the most consistent, while surgical and non-traditional medical director administrative services have the most fluctuations. And in this chart, you can also see the same bifurcation of rates between medical subspecialties and surgical as well. The most growth has been observed in leadership, and non-medical director positions. And by those, what I mean are non-specialty specific medical directorships like care and case management, utilization management, quality initiatives, teaching, data management, etc. On slide 24, earlier in the presentation, we discussed that fewer doctors are willing to take on administrative roles, and that is frankly quite understandable, as there have generally been upticks in time commitments for these services over the years. The time spent in these roles on an annual basis is a meaningful investment of time, particularly for, as you can see on this slide, care and case management. On this chart, we are looking at median annual hours performed in these roles per the physician's contractual obligations. On slide 25, given that we've mentioned evolutions in annual hours for these positions, let's discuss specialty-specific medical directorships with the highest median hours reported over the past couple of years. There have been increases in time requirements for both psych hospitalists and maternal fetal medicine, as illustrated in the chart. Now, just to ground us in understanding of the time commitments, if we assume that an FTE is 2080 hours a year, which I acknowledge can differ between organizations and even between specialties, the most time-intensive directorships take up about 20 to 30% of an FTE. So that is meaningful time. On slide 26, we are sharing the highest paid median physician administrative roles that aren't specialty-specific medical directorships. Some of these services on this chart did experience growth while others didn't. Note that the largest increase, research and data management, wasn't the highest paid. On slide 27, I want to shift gears and talk more about ED call coverage. Now, I really try not to play favorites, but I really do enjoy discussing ED coverage trends. Coverage is a significant area of spending for many of our subscribing hospitals, and we report coverage payments for over 50 distinct services. Over the past decade, medical subspecialties have seen significant growth in rates over time, which might be playing catch up with the surgical specialties. However, we continue to see pressure on rates for a selected number of surgical specialties too, of course. ED call continues to be a challenge for hospitals that contract with community physicians to provide coverage because of lifestyle preferences, reimbursement changes, concurrent and regional call panels, and other market factors and complexities. Regardless of this, however, our new data suggests somewhat less pressure on ED call coverage arrangements compared to the previous year. However, there are absolutely exceptions to this. Across all services we reported, ED per diem rates increased an average of 5.7% at the median, but only 2.8% at the 75th percentile. So compared to the 2023 inflation rate, increases at the median were higher than inflation. However, we observed that 4 specialties increased more than 20% at the median: oral, maxillofacial, pediatric orthopedic surgery, gynecology, and anesthesia. Now on slide 28, I want to talk about what statistically impacts ED call rates from the analysis we do every year. I also want to share some observations on the impacts to administrative rates just for some points of comparison. So physician specialty and job description are generally the most important factors in payment rates, which is kind of a duh. Higher paid specialties will demand more, not just for ED coverage, but also for administrative services, right? Given their more significant opportunity costs. However, this doesn't seem to apply to most administrative roles that don't depend on a specific specialty to perform them. So think chief of staff, payments for attending meetings, being on committees. This is likely driven by more of a compliance mandate to compensate those services consistently, regardless of the specialty of the physician serving in the role. Furthermore, MD Ranger observes sometimes organizations have a standard medical directorship hourly rate that they apply across all specialties. This doesn't happen everywhere, but it does happen some places. Trauma status is also an important factor, likely reflecting higher call burden, higher patient acuity, and more complex organizations requiring higher time commitments, even for administrative tasks. The impact of being a level 1 or level 2 trauma centers translate to a 22% premium on ED call coverage agreements compared to non-trauma facilities. Hospital size also matters. Not only does increasing ADC have an impact on call rates, it also has an impact on the number of hours that medical directors work annually. So what doesn't influence physician contracting rates? From a statistical standpoint, one of the surprising things we found over our years of analysis is that payer mix, whether good or bad, has no statistically significant impact on physician payment rates. However, and this is an important nuance, it is considered appropriate to take into account payer mix when determining payment rates to physicians for ED coverage. Ownership status is something else that doesn't impact rates, so whether or not the hospital is independent or they're part of the system. Now on slide 29, I want to talk about regional call panels or coverage agreements that incorporate multiple facilities across a limited yet appropriate geographic area. As more systems consolidate, we are seeing more of these arrangements being negotiated. Now, the number of campuses included in a call coverage contract does influence the rates. We perform a 3-year rolling average to calculate what we call the additional campus factor. Coverage is not just simply 100% of the rate for each campus. Based off our analysis of these arrangements, each campus should be 44% of the single campus rate. So I'll give you an example to help illustrate the point. If a single campus rate is $1,000 per diem, the 2 campus rate for a single doctor covering those campuses would be $1,440, 3 campus rate $1,880, 4th campus rate $2,320, yada yada. So as you can see, the per campus savings goes up as the number of campuses increase. Though realistically for call coverage, it's rarely more than 3, most likely 2. Now, for medical direction, multi-campus positions are more common, particularly for large systems. For these arrangements, the hourly rate for multi-campus deals is 12% higher, and the number of hours goes up by 15.4% as the hospital grows by 10% average daily census. Okay, so on slide 30, we're gonna jump back into looking at individual benchmarks. On this slide, we're seeing ED coverage services that have experienced the most dramatic increases over the years. Vascular and plastic surgery are taking the cake for the largest increases this year. More broadly over the past decade, MD Ranger has observed more than a 30% rise in rates across 50+ specialties. Now, at first blush, this could sound high to you, but when you're looking at the changes annually, it only averages out to around 4% per year, which depending on the year, may or may not be in pace with inflation. Now on slide 31, as reflected in medical directorships, there is a bifurcation in medical versus surgical rates for ED call per diems too. So here we're looking at some 5-year trends in call coverage medians across medical and surgical specialties. On slide 32, because MD Ranger collects all contracts from the hospitals we work with, we can determine how many of our subscribers pay for a specific service offered at their organization. We refer to these statistics as our percent paying benchmarks. For this slide, we highlighted the emergency department call services that are most commonly paid for based on having the highest percent paying metric in our database. This can be a very useful metric to include in commercial reasonableness assessments, which of course, as I'm sure you remember, should be done in tandem with your F&V analysis and documentation for all your physician transactions. So as illustrated on this slide, according to our database, ortho, urology, general surgery, and GI have similar metrics regarding their frequency of call pay at facilities. On slide 33, we're going to be viewing the highest per diem rates in our database. Now, trauma and orthopedic trauma have always commanded high rates because of the nature of the service. Interventional services, and in particular neurointerventional services, have really been a trending topic over the past few years, and we've seen rates really go up quite a bit for this service. Again, interventional radiology and neurology, very hot topics also for our consulting practice over the past few years. Now on slide 34, I'd like to take a look at the shifts in the quantiles for ED coverage services over the past decade, categorized by surgical versus medical subspecialties. Now, while medical subspecialties percentiles are growing closer over time, surgical specialty per diem quantiles have generally grown farther apart. So interesting. Another important note here is the legend. Surgical specialties are much higher than medical, so look at that y-axis again. It's something you should keep in mind when viewing these charts side by side, and it makes the observation we discussed even more pronounced. On slide 35, in an attempt to contain ED call costs, some hospitals opt not to pay a per diem, but rather look to alternative payments like activation and per episode rates, and we're sharing some of those on this slide. Some hospitals are using a second payment method like activation and episodic payments to keep from increasing that per diem rate, which can get really expensive over 365 days of the year. Activation payments are defined as pay for calling a physician into the ED to see one or more patients. A per episode payment is tied to an individual patient encounter. Recently, we are starting to see some further differentiation of per episode payments into E&M versus procedural encounters being paid with per procedure rates. Now, just to name a few benchmarks that we have in MD Ranger, we have ophthalmology and psychiatry for per episode benchmarks, and dialysis, ERCP, gastroenterology, surgical assist, among many others. I think there's at least a couple dozen in per procedure. Now on slide 36, even before the pandemic, telemedicine was a trend. Over the past 3 or so years, we've seen a definite uptick in the number and type of arrangements among MD Ranger subscribers. In 2019, we started benchmarking telemedicine rates that were structured in a variety of ways, including monthly plus a per episode, and per episode only. Many contracts in our database are paid monthly, regardless of the number of encounters. We've also witnessed a growth in the number of telepsych and teleneurology contracts, which could be a means of addressing ED call panel challenges, enhancing access, reducing coverage costs, and then reducing demands on local physicians. On slide 37, our last chart today covers clinical hourly payments for services performed in either inpatient settings or in hospital-affiliated clinics. For these contracts, physicians do not bill and collect for services in these circumstances, unlike our benchmarks for ED call, and separate benefits are not paid. Not surprisingly, these rates generally reflect typical salary ranges for the specialty. Over the past 3 to 5 years, we've greatly increased the number of specialties we can report for this service. We have over 50 specialties now for clinical hourly rate benchmarks. And in addition to the clinical hourly rate benchmarks, we don't have time to show them, unfortunately, we also have locum tenens rates as a part of MD Ranger. So the next slide concludes our webinar. Before I take a couple minutes to answer questions, I just want to leave you with a few thoughts today. So as we wrap up our time together, you may have seen some data or heard about industry pain points that might resonate with you. Maybe you're finding the FMV process and managing physician transactions overwhelming and challenging, or maybe your organization is currently purchasing survey data, but you feel like the survey isn't delivering the insights you need or insights you can take action on. If any of this strikes a chord, I encourage you to share this webinar with others at your organization and consider if you think there's a way our data, technology, and consulting could help provider compensation and compliance at your organization. So if you're nodding your head along, I'd love to continue the conversation. That's my contact info on the slide. I'd love to hear from you. Thank you so much for your time today. We're looking forward to hosting you at a future ECG webinar. And that's it.
Thank you, Allison. A quick reminder to our audience, please continue to enter your questions into the question pane, and we will respond to as many as we have time, or as many as we can with the time we have left. Our first question is, given the complexities of physician contracts, how should organizations go about creating a policy that encompasses all transactions?
Okay, so it is great that you're thinking about pulling together an official policy for physician transactions. So yay, kudos. First step. It is possible to create a policy that integrates just simple, straightforward guidelines, and many, if not most of your transaction should fit in those boundaries. But not all transactions are going to necessarily fit within your framework, okay? So there will always be those handful of transactions that are either like well above market, or they're super complex or politically fraught or whatever, and they just can't be documented using your organization's kind of set forth policy and guardrails. So that's why I think one of the key elements of your FMV policy should include procedures on how to address contracts that fall outside of the scope of your framework and your definitions. And this way you can handle those exceptions consistently. Now, it is highly likely that for these transactions, you will need the assistance of a valuation consultant, your legal team, your compliance team, so it will definitely be a team effort. Lastly, I just want to say that we do have resources at ECG and MD Ranger to help organizations craft a policy. So if this is something that the person that asked this question wants to go deeper in, we can definitely send you something and follow up.
Thanks, Allison. The next question is, given the increasing complexity of hospital-based physician contracts, how are hospitals managing the financial support for expanding specialty teams like psychiatry and neurointensive care?
Oh boy. So like for sure, the increasing cost of hospital-based doctors is driving up hospital costs. And given the already excruciating pressure on margins, this is no doubt of concern to many hospital leaders. Just one of the trends, to pick one, that we're seeing is in response in this, or it could be in response to this, is that more health systems are pursuing system-wide contracts with larger national staffing firms who can staff hospital-based services with much greater economies of scale. And we see organizations moving away from the kind of traditional local single site, private practice staffing model. Now, as I mentioned earlier, the growth of these groups could also be impacted by the fact that physicians are seeking more stability and security through employment. So these care models could be a more favorable choice as opposed to running their own private practice.
Okay, we have time for one more quick question.
Okay.
That is, with physician shortages and an increasing number of part-time physicians, what strategies are hospitals adopting to ensure continuous and effective patient care?
Okay. We could probably have another webinar on this, but my high-level thoughts in 1 minute or less. So first, more and more hospitals and healthcare systems are choosing to employ doctors when they can. I know not everyone can. If they can't, or in other circumstances, there are definitely other alignment strategies to consider. So think of things like co-management agreements, more focused and robust telemedicine strategies, things of that nature. We're having to get creative. But ultimately, it's so important that organizations focus on recruitment and retention. It's just critical to keep the providers that you have engaged. And lastly, kind of related to my response to the previous question about staffing organizations, these MSOs, these physician staffing companies, have also stepped into a role here and are helping hospitals and health systems ensure continuous and high quality care.
Thanks, Allison. That's all the time we have for Q&A today. That concludes today's program. Please note that if you asked a question that we were unable to get to, we will follow up with you after the session. We would also like to make you aware that ECG's extensive library of thought leadership content. Visit our website at www.ecgmc to learn more about these relevant and timely topics. I would like to again thank you all for attending today's presentation. If you have any additional questions or comments, please don't hesitate to contact Allison via the email information provided in the handout. And one final reminder, we would greatly appreciate you to take a moment to complete the electronic survey upon exiting today's program. As stated earlier, ECG will make a $5 donation to Doctors Without Borders for each survey submitted. Thank you, everyone, and have a great day.